Hey everybody, welcome to Purple Friends. I am your co-host, Co.
And I'm your co-host, Joe.
I keep thinking you're going to say Joe-host, Joe.
My brain does not, especially today, is not working that fast.
That's okay. Welcome everybody. Welcome back to the podcast.
Welcome back.
And to any new listeners we have after last week's episode, welcome.
Yeah, welcome. Last week's episode definitely... y'all liked it, so thank you so much because we really liked it, and we just noticed more listeners on this particular episode. So,
yeah,
if you're following from that episode, hello,
hi, welcome
we're your
aboard.
Yeah, we're your purple friends,
And now you are our purple friends. We gotcha.
What are we talking about? Oh, well, before we get you go.
well, I'll go. Are you talking Little Gratefuls? Or are you talking what?
I was going to introduce the topic.
We should introduce the topic first to tease them so that people don't just bounce when they hear us start talking about personal stuff that doesn't matter to them.
Yeah, true. Today we're going to be diving into diagnosing and diagnoses. So that'll be really fun. But before we get to that, like Corey said.
Yeah, you know what we do here. It's time to say something we're grateful for. That little grateful. Mm-hmm. You want me to go first?
Yeah.
Mine's kind of a big one.
Do it.
Okay. Well, I'm just really grateful for the response that we got for the last episode. Because like we heard from so many different people and like that they shared it with other people. And that was just so meaningful to me. And I just really appreciate that. That was just so cool.
Yeah. And it's cool too to like, I think it was our fourth best overall episode, which I know maybe doesn't sound super impressive, but
based on our statistics, that's actually very impressive.
Very impressive because our numbers have slowly been declining since the first episode. So to see a nice little spike,
yeah, we love that.
Yeah, was very encouraging, and we're just happy that to the 17 listeners that y'all are here with us.
And if you can believe it. As soon as we were done recording, the first thing I did was I looked at Joe and I said, I have so much more to say about autism.
We literally, you came up with a whole second draft for a continuation of last week's episode.
Yes.
Which we were going to record today, but...
I'll speak on that.
Sure.
I think that we talked a lot about it last episode, and I want to save it because there's probably going to be some big stuff happening in the autism world in a few months. So we will have that second episode for you whenever people decide that it's Autism Awareness Month again.
Yeah. Right.
And just to give you a preview, I literally have already outlined the episode. I'm just going to say the bold topics that we're going to talk about in episode 2. More common misconceptions, the pinwheel visualization of autism, making spaces more friendly for autistic people, getting along with your autistic coworkers, supporting an autistic partner, how to build an autistic support group. That's really more about for us and other private practices, but rates of intersectional autism, rates of transgender, asexual, and queer identification. Is ADHD part of the spectrum? How little we truly know about comorbidities with melatonin, SSRI usage, blood glucose regulation. What actually changes when you get an autism diagnosis, whether you're a kid or an adult? What resources do you get whether you're a kid versus an adult? More about ABA therapy, the thing that we so maligned last time, and we're going to be digging our heels in and sticking to our guns on that one. More about facilitated communication and history, more about autism and poverty, homelessness, incarceration, common causes of death, but also some more hope for the future.
Yes.
So that is what you have in store next time.
Yes.
But not this time.
As you can see, clearly we have lots of information, lots of thoughts, because it's important to us. And last episode was maybe just the tip of the iceberg. And again, we're just excited that people enjoyed it and it resonated.
So if you're here because you like that episode, stick around. There's going to be another one of those in probably a few months.
Yeah. Okay.
What are you grateful for, buddy?
Yeah, my little grateful is, of course, kites.
Yay! Flying kites.
Yes, I love flying kites. 2 years ago, we went to Wheaton's Kite Flying Fest.
Yeah, go fly a kite.
Yeah, and that was the first time I had ever flown a kite ever in my life. And I fell in love instantly. I was all about it, and I bought more kites, and I went to the Wheaton Kite Fest again last year and again this year. And you got me a very cool kite for Mother's Day.
Oh, yeah.
And I got myself a very cool kite at Kite Fest.
Well,
and
if I may say, for Mother's Day, even cooler than a kite were the kite
real
accessories.
Yeah. He got me a bunch of really cool kite accessories, which you might be thinking, I mean, how many accessories can there be to fly a kite?
Check it out. Look up what an anemometer is. It's a little thingy that tells you how fast and what direction the wind is going. It's got a little fan in it.
You cannot underestimate how much joy I get from using that little thing. I just feel like such a cool kite nerd, you know? Like I got my kite, I have gloves. I have this really cool reel, like a fishing reel, but it's like for kites.
It is heavy duty.
It is heavy duty.
It's circular. It's really interesting looking.
It's pink, which I love. And yeah, my kite and the reel accidentally slipped from my hands last time I was kite flying, and a lovely passerby rescued my kite, but that reel was so heavy duty, I'm pretty sure poor man got hurt just trying to rescue my kite. So thank you to this person,
this poor injured Good Samaritan.
But you know what, he and his kids or his nieces and whoever he was with ended up flying kites after they saw me fly kites.
That's right. They went home and got their kites.
And like truly, there's just so much joy that comes with it. I mean, I think it feels like you're flying, or the closest thing to flying.
Yeah, you really feel like the wind.
Yes. It's so, I love it. And also you get a lot of little visitors, you know, lots of little kids that are interested in the kites.
Especially if you got a cool kite.
If I got cool kites, big kites, they want to hold the reel. They want to pick whichever one comes next. It's just very fun, and it's brought me lots of joy in the last few weeks now that the weather is finally getting warmer, although today is still kind of kind of chilly.
Yes, we definitely have plans to go kite flying tomorrow, probably today too.
I'm probably going to go today.
Yeah.
My usual spots are Graff Park and Newton Park in Wheaton. If
this is a pretty local podcast, so you know.
If you see a
big cobra in the sky, like a 45-foot cobra, it's
mine.
Yeah.
Okay, shall we get into it then?
I would love to.
Okay. So like I mentioned, this was my idea. This topic was my idea for today's podcast episode. Thank you. I mentioned it earlier in the opening that my brain is just not working fast today. It's so sorry.
That's okay.
Around diagnosing, mostly just because, I mean, it's such a crucial part of my job, but it's also such a crucial part of my clients' journeys.
Yeah.
You know? And so I do a lot of psychoeducation with my clients and with students when I was teaching around diagnosing. Today, we're not going to go through the whole DSM and talk about like different, you know, mental illnesses and criteria to meet them. But
there's probably other podcasts that do that.
Yes.
It's probably hard work.
Yes. I mean, if you are interested in like a rundown on like all the, maybe that might,
we could like, open the DSM, like common conditions.
Yeah. And we can talk about if that's something that y'all are interested in.
Yeah.
But today's episode is more so on like thoughts and the impact of
the experience
of diagnosis. So from a psychological perspective, right, mental health diagnosis is more of a formal identification of a pattern of thoughts, feelings, behaviors that cause distress or impairment in functioning. This is based on established criteria. So like I mentioned earlier, like anxiety has
a DSM page.
Yes, a DSM page, and there's like a literal list of criteria that you
Client
need.
Must exhibit these three to five of these things, or 3 of these 5 things for X amount of time to be considered having this.
Correct. And so that's all diagnosing is, right? It's just a pattern. It's just really formal language to categorize, make sense of, and to streamline conversations and understanding around what someone is experiencing, right? Because if I were to, for example, I do a lot of consultation or like working with other professionals in client treatment. So if I were to go to like a teacher and be like, hey, I have a mutual client with one of your students, and this client is exhibiting, has trouble sitting down and can't focus and, is fidgety. Like that could take a lot longer than like, hey, we have a mutual client that's experiencing ADHD symptoms. Again, it's just kind of common language. So it really helps with the mental health professionals and other healthcare professionals have conversations and create treatment plans for any of these diagnoses.
It's really interesting because it is kind of different than like when you would go to a doctor's office for a diagnosis. If you did like a blood test and they found like something physiological, like this is like you check 3 of these 5 things. It's a very different type of diagnosis.
And
it feels like.
I mean, like I used to teach clinical interviewing, which essentially was interviewing a client with a clinical perspective to gain a diagnosis. So asking about people's psychosocial backgrounds, psychosocial emotional backgrounds, to see if there are any of these patterns emerging, and there is a risk of some, what's the word? Subjectivity.
Oh, yeah. Any kind of like personal bias.
Yeah. I mean, and we'll talk more about that with intersectionality, right? Like,
yes. Anything that needs to be like assessed or interpreted.
Yes. Something
can
like
be subject to personal bias.
Absolutely. I mean, and my perspective, I might see something as like an anxious symptom when someone else might see that as an ADHD symptom, So like, again, we are trained to even like differentiate between those things, but we still make mistakes. It's still hard, especially because every individual is so different, And I think that brings us into this other point, really a common misconception around diagnosing, that it's like this label that defines someone, right?
Yeah, forever.
Yes, forever. I have depression, always and forever. I have, ADHD, always and forever. And it's important to remember that like, it really just describes a set of symptoms during a particular point in time. And that's still so true. Like, we talked about a good example of this would be depression, right? Like even in diagnosing, like when I put a diagnosis in the computer to send to insurance companies, it says an episode, right? A major depressive episode, right? And so another version of that diagnosis is major depressive episode. What is it? Resolved, So like that you're not currently having a depressive episode. Right. So you might not be able to show any of the symptoms that would grant you a diagnosis, right? But the history still gives you the diagnoses, right? That's why it's so important to have those kind of understand, like getting to know the client. What is your history? What about your family? All these kinds of things do impact or like influence diagnoses, but it does not describe any one person, and they are essentially pretty episodic. I don't know if you want to speak
about what it's like.
Yeah.
Well, sure. I mean, I could. Oh, that is my role here. I'm a mental health haver. Take your pick. Are we talking about depression?
I was thinking more autism.
Oh, okay. Yeah, we'll talk about autism. Okay, so autism is a really interesting example, actually, because like you wouldn't think of autism as having like episodes or anything like that.
Yeah, that's why I wanted for you to talk about a little bit more about that and how it pertains to a particular period,
right,
or point in time.
So like experientially, like living with autism, and I'm sure that most people with autism would agree with this, there are things that can contribute to making your autistic traits much more prevalent or sensitive. So like if you don't get enough sleep or if you're really stressed, you may be like much more irritable, much quicker to snap at like loud noises that you normally would be able to stand might cause you to like literally like yelp.
Yeah. Like your threshold changes.
Yes, totally. Like it's kind of like how when you're really, really sleep deprived, like everything just kind of like sucks a little bit more.
or I mean, we commonly use the word hangry.
Yeah.
You know, when we're hungry, we know our mood changes, our threshold to certain things changes, our patience changes.
Yeah.
Like,
so different physiological stresses really can make these different things fluctuate.
right. And things like anxiety and depression, for example, oftentimes can be very episodic, you know, like there's like finals week, for example. I see a lot of clients during finals week because they're really stressing, or right after to process, or, you know, right before to prepare. Like that increases the need, or even just the awareness of like, wow, I really am having these feelings, and it's really hard to ignore right now. So yeah, it's important to remember that, like, we, especially our psyche, I feel like shows up differently every day.
Yes. I mean, definitely for some people, just like, I don't know, maybe some people don't feel this way, but I definitely feel like when I wake up, I have to like assess to like to figure out what's going on. And sometimes when I do that assessment, things come up rough.
Yeah. And like, I do that, and I encourage my clients to do that, you know, to practice that. Attunement is what I call it.
Oh, okay. Yeah.
You know, just being more attuned to yourself. What are your needs? What's going on? How are you feeling? You know, so that you can better prep your day,
Yes.
you know?
Oh, a lot of what we're talking about too, like when you're really tired, it makes it harder to respond to your body's signals and stuff like that. Being it's more difficult to understand what's going on in your body. Your perception of what's going on in your body is called interoception. So like
Last night,
what do you mean?
when I was struggling with the snack,
Oh,
that's, I think, a really good example of that. Like last night I was beyond tired. I was so exhausted. And it was really hard for me to recognize my body signals. Like I made myself a snack. I got myself like an apple and peanut butter and like a drink, and I didn't eat it.
Yeah.
Like that was not what my body needed, but that's what I thought my body needed. I was so tired that I was just trying to solve a problem.
Yeah.
And I ended up solving a problem that I didn't have. Really, I just needed to go to bed.
it's something that happens a lot. Like, it's going to sound really silly, but I struggle with this. This is something that we have to remind kids of. Like, are you hungry or are you just thirsty? Like, that's something that I personally have to like evaluate every time I open the cupboard.
But I think that's a really good point, right? Like, and I say this a lot for clients, is that like there are some days where it's just easier for us to go there and to manage or to challenge our anxious thoughts, for example. And there are other days where it's so much more challenging and much more of a chore, and it's much more of a fight, you know? And I think in those days, the priority needs to shift. I think this kind of goes into a different conversation, but like, yeah, the priority needs to shift if you are feeling so fried and spent, you know, like,
Right. Like if you're experiencing executive dysfunction, like you're like the stereotype of like, you're so depressed that you can't get out of bed,
truly.
or like you can't get yourself to do any stuff. You're like totally anhedonic, meaning like you can't find pleasure in the stuff that you normally like to do. Yeah. But the thing, like to bring it back to what we were talking about, like that's an example of something that's episodic. And the thing about a lot of diagnoses in the DSM, and you can speak much more to this than I can, but like a lot of them have to do with like a duration or a time period. I'll have to double check if there are any that aren't. But when you're in the DSM and you're reading the criteria, all of them have time specificities, you know, like for more than 2 weeks, for longer than a year. Right.
If persists for, you know, longer than a year, but less than 3, then it's this. If it's longer than 3, then it's, yeah. So the timing of a lot of these symptoms matters greatly. And I think it's important too to remember when you're also self-evaluating. I say this all the time. You are the expert of your life. You're the only person who's living your life. You're the only one who can say what you feel, what's going on in your body, your experiences. And with that being said, right, I think that if you've ever experienced a time where you might be feeling or thinking like, oh, I might have this, or, you know, this, I'm noticing this pattern, or I'm concerned about this, that matters greatly.
Yeah.
You know, I take that into full account. And oftentimes, like I said, when you're having that self-evaluation, keeping in mind, how are you feeling in that day? You know, is it one of those days where symptoms or patterns are more pronounced, or is it a day where it's a little easier? And I think that's why, like, seeking a professional or having a third party observer really helps, like, differentiate from that and say, like, yeah, today might be a really good day, but that doesn't mean that you don't have this diagnosis, you know, or this pattern, or that it doesn't come up every once in a while.
And if you're the kind of person who thinks like, or struggles with like remembering or identifying patterns or whatever, like in your life, like I've been experiencing this for a long time or whatever, I really want to put in a good word for journaling. Because you are basically the only witness to your thoughts and feelings. And if you forget about them, they're gone. So it's really important to record like things when you, like times when you felt really stressed out, or like, or try to reflect on what might have caused it and stuff like that. Because no one, even a therapist, isn't going to do that for you. You have to be able to like identify a situation and bring it to a therapist in order to work through it.
Yeah, I so appreciate you saying that. I feel like it's lost all meaning when I say it. Because I say it, I just recommend it so often. And I feel like journaling is one of those things that is just hard to engage with sometimes.
Yeah.
But you're right. You're absolutely right. Also, I'm an avid journaler. It hits so different when you read your own words. When you read your own words and you reflect, wow, I was really feeling that then. Look at how far I've come. Or wow, look at how things have changed, or how much I've grown, or even if it's a negative or different kind of feel, like knowing that you could feel that good, or like, wow, things were that great, or I felt that, like, it hits so different when it's your own words. It puts you back in that moment. It reminds you that this feeling is possible again, or again, it confirms like, wow, I really have grown. So yes, journaling, we're big avid journalers, and we highly recommend it.
I'm an on-again, off-again journaler, but I did recently...
But you use it for what you need it for, and it still hits.
And journaling can take a lot of forms. I just want to say, like, you don't have to be like literally writing in long form your thoughts. Like a lot of people, like I personally use an app called Dailyo. I think we've talked about it before on the show, but like, just like a way to record how you were feeling over time is really what journaling is about ultimately. Yes.
It can be as easy as like what Dailyo is, which is just rating your mood a couple times a day and reflecting on that a little bit. If you even want to. Optional. It can be, jotting a list in your notes app, texting yourself, dictating things, leaving like, yourself little breadcrumbs. They don't all have to be in one journal. Exactly. Like the journal I use is also my planner. So like it serves dual function, you know? Anyway, okay. Should we get into some of the research? I would love to. This time bringing research. I didn't read a book this time. In 2011, there was research that showed, that emphasized that diagnosis often reflects a vulnerability rather than a predetermined outcome. So what that kind of meant was like the way that people viewed diagnoses, and still do, is sort of like outcome based. So like when somebody gets, we keep coming back to this example because it's the one that I know the most about. On top of our head right now. An autism diagnosis, right? The thing that comes to most people's minds is like the pathology, the what's going to happen to the family, to the kid, the future, that kind of stuff. Rather than that, the way to think about a diagnosis would be much more, I guess you would say like a more positive outlook. A better way to use a diagnosis is to think about it as a vulnerability rather than a predetermined outcome. Like, I know I just repeated the words that I just said, but no, but I think that what you're getting at is that it doesn't mean X an X life.
Yes.
You
Like
know?
you are not going to, a diagnosis doesn't mean you're going to be X statistic.
Correct.
What it does mean is like you need support
In these particular
ways.
areas. Yeah.
Right.
And you're right. I think that's a wonderful way to look at it, because I think the opposite is often true, that
Yeah.
like, you're right. We get a diagnosis and then it's like we fill in all the blanks, you know, and then we run the risk of a like self-fulfilling prophecy, which has its challenges too, you know.
Yeah.
But,
I mean, it is a 70-year-old theory.
yeah. But I think that we've all kind of maybe identified that feeling before, or like are aware of that as a diagnostic challenge of like, if I diagnose this child with depression, are they more likely to then identify with or adhere to depressive symptoms to kind of
live
confirm
with more depressive episodes,
confirm or validate that diagnosis? And it's just like, not necessarily.
Yeah, this research sort of proved that is not really reality.
Correct.
And then a 2020 study, the impact it was examined the impact of receiving a mental health diagnosis on like an individual's sense of self, and the positive outcomes and also the negative outcomes, because we talked about this a lot in the autism episode, but like a lot of people don't really think about in general the negative outcomes associated with mental health diagnosis. Well, I shouldn't say a lot of people. There's a lot of people who are so anti-mental health that that's all they think about. But yes, there's drawbacks and benefits usually with almost any diagnosis.
Absolutely. So yeah, keeping that in mind, I think, is important. Plus, I think I'm just trying to think of when I want to talk about like self-diagnosing and TikTok diagnosing and, social media diagnosing and fads and trends and those types of things. Because especially in the last 10, 15 years, like, and even more specifically with like mental health diagnosing in the last 5-ish years, I'd say, since maybe COVID, just how prevalent that is.
Yeah.
Like reels or TikToks of mental health symptoms, like you may have ADHD if you experience XYZ, and they're like so non-specific. And then
oh my gosh, yes, you see, my feed is inundated with you might have autism if 1, 2, 3, and it's like so not it.
Yes, they're not DSM criteria. Like these are not mental health professionals. I will talk about like the validity behind relatability, like, oh God, I have so many thoughts that are trying to come out of my mouth right now. But I see it so often in my office where like a lot of the times people are in my office because it's sparked by a reel or a TikTok. And like I said, I think that you are the expert in your life. And if you something about this TikTok or reel resonates with you, I want to talk about it. I want to hear about it. I want to think, okay, if you think you have ADHD, I want to hear about why you think that. Because like I said, you are the expert. I take that greatly. And if you think or suspect that you might have OCD or ADHD or whatever else because of what you've seen on social media, I want to start there and unpack that. Now, that doesn't mean that I think that social media is at all a reliable or effective way of diagnosing yourself.
No.
I think it can be a starting point to a conversation, or even just practicing that self-awareness of identifying like, oh, I'm seeing these symptoms in someone's reel. I also relate to those symptoms, right? It just gets really dicey when we start self-diagnosing.
Yeah. I think the thing to remember about like, if you're not a person who to refrain from like judging people who self-diagnose, because like ultimately they're experiencing something that like they can't explain. There's something wrong and like they're looking for an answer.
Right. And that's kind of what I'm saying is that like that experience is valid.
Yeah. And that is especially like if you, those kind of like what you said, I'm not going to say it's beneficial because like obviously it leads to a lot of like really ill-advised self-diagnoses, but like if it gets somebody into a therapist's office,
correct,
that one was beneficial.
Or if it gets you just thinking about your mental health, thinking about your own patterns, your own thoughts, your own beliefs, and how they impact your day to day. Again, I don't think there's anything wrong with that. And like I said, you are the expert. I think we're definitely going to talk about it more when it comes to like maybe not getting validation through your mental health professionals or your medical professionals even. That sometimes self-diagnose is the only time like that you can say like, at least someone gets it. I feel seen in this way, or I feel validated in this way. 'Cause there's a lot of problems in these fields that honestly, I think leave a lot of people falling through the cracks, unseen, untreated. And like, that's kind of where that leaves, like you said, having a lot of empathy for people who do self-diagnose. I think that's where a lot of people who do self-diagnose find themselves. It's just like, I've been to therapy 1,000 times and no one seems to think I have OCD, or they seem to think it's this, or they minimize it, or it's whatever. And I'm certain that I've probably done that to someone. Like I'm sure, like I'm not the expert in those people's lives, and I'm sure I miss it. But that's why, like, I'm especially now, like, still trying to modify my practice and be open to learning new things and challenging my own biases still every single day. Like, yeah, I don't know where I was going with that.
Basically, we have a lot of empathy for people with self-diagnosis.
Yes. Yeah. I mean, I don't know why I'm thinking now about stigmas and...
Well, I mean, that's a really important thing. Like when I mentioned earlier about like potential negatives and drawbacks, that's really the main thing that I'm talking about is like the stigma. But the thing to remember is like if you're afraid of like sharing something and being stigmatized, your diagnosis is your personal health information, PHI. That is like a literally protected type of information. You don't have to share that with anybody. You can take that to your grave if you want to. I'm not saying that that's necessarily healthy, but if you're surrounded in an environment where you would be, persecuted in some way, then yeah, I would say go ahead and hang on to that information.
Yeah. In an ideal world, I would love clients to integrate their diagnoses and not be afraid to say, hey, I have this.
Yeah.
And like, this is why I do things differently. Yep. Like, this is why I learn differently, or this is why I'm move a little slower, or whatever else. I was literally just talking to a client about this yesterday that anyway.
But the reality is like, if you were to take the time to explain that or like to broadcast that, that would make you a target in some ways.
In this unideal world, yes, absolutely.
Especially, the current
situation. Especially now. Oh my God. Yes. I mean, like, it is so unsafe to honestly, to self-disclose many parts of our lives.
Yep.
So obviously this is a very different situation. We want to be mindful of that. And I think you spoke about this last week of just like wanting to protect yourself and like stopping to pursue a more formal diagnosis because of the fear of persecution or stigma.
And also like speaking on, to try and jump back a little bit about like why, another reason why people might self-diagnose is accessibility. You might not have access to care like in your area or like whatever in your price range, anything, whatever it is. That doesn't mean that you should like go your whole life feeling like, like there's something wrong, but you don't know what it is.
Yeah.
Like it's really important to do a lot of research and stuff like that. And not necessarily pro self-diagnosis, but I'm not anti self-diagnosis. I think the thing that is a problem is, like you said, the people on TikTok and Instagram is like, you have to remember that like, if you want to like, how do I phrase this? If you want to challenge the established system of what constitutes a diagnosis, you need to at least have the knowledge of like the current system and what's wrong with it before you come up with a new idea. Like what I'm saying is someone would have to be a mental health professional to look at the DSM and say, this is wrong and this is what it should be.
Yeah.
It would take a lot of research. It would not take someone on TikTok who's like doing jumping jacks and pointing at 3 bullet points on the side of their body.
Yes. I mean, I do see a lot of mental health professionals or just medical professionals on TikTok, on social media, trying to psychoeducate. I mean, I do that. I try to psychoeducate. I don't think there's anything wrong with that. Again, it's these more vague reels that like really could apply to anybody. I see especially around autism and ADHD, especially I've been seeing more recently of like, just honestly sound like pretty normal things, and not trying to invalidate those experiences for those people. But like I said, that's where it becomes a slippery slope, and just wanting people to be aware of that. There was something that you had said that brought something to my mind. Oh, that like, I wanted to briefly talk about why people might be seeking a diagnosis. I know we've already talked about that a little bit, but like, because like I think about what is the purpose of diagnosing, right? Like, what would someone getting an ADHD diagnosis really do for their lives? You know, it doesn't change them. And again, like that's kind of the whole argument here, is that like receiving any diagnosis does not change you as a person. Does not change who you are, how your life turns out. Like it doesn't, right? Like having that title doesn't change your makeup.
No.
But it can provide relief. It can provide resources, accountability. What was it? The other one? Accommodations. I was like, there's another A word. I can't think of it. My brain today. But anyway, it can provide those things.
Yes. When we talk about like, I don't know what number of these diagnoses that we're basically always talking about, like depression, anxiety, ADHD, autism, OCD, like this category of diagnoses. That's basically what we're always talking about here.
Is your brain too farting a lot today?
Yes. Oh, I got it. So those diagnoses that we're talking about, when you get diagnosed with them can make a big difference. So when you're diagnosed as a kid versus as an adult, when you're a kid, you can get stuff like resources in school.
Accommodations.
Accommodations. You get access to different prescriptions and stuff like that. When you're an adult, you really just get the prescriptions, and that's if you can convince your doctor.
Yeah. I mean, some cases you might get like workplace accommodations, or like, again, people who are filing for disability or other kind of like government, what's left of them, government funded programs.
Wait, none.
Sorry.
So yeah, I know. We're laughing because like we're like that dog with everything's on fire. It's fine.
It's fine. Everything's fine. But anyway, like those are very tangible things that having a formal diagnosis can afford you. But there are some situations, like I keep thinking back to this one particular client that I have, that I worked so hard on having them have psych testing so that they can get their, which I fully suspect and still think this person has autism. And they were denied.
Yeah.
They were denied. And like we had this whole conversation around like how they are the expert in their life and how they felt that certain things in their report were completely unfounded, and how like they didn't see some like stimming, for example. One of the things that my client mentioned, and the person who evaluated her didn't view that as like a stim, or wasn't severe enough or wasn't intense enough or whatever else was socially acceptable enough to where it didn't count. And I think, again, those are the moments where it's just like, where do you go from here?
That's so basic. Like,
so yes, I know.
An adult woman who is good at masking. That's so obvious.
Yeah. I mean, it's it's so frustrating.
Yeah, that's what I'm talking about when I talk about how I have a whole other episode about autism stuff, guys.
Yes. I apologize that we keep using autism as like an example. Again, it's just kind of like top of mind and really relevant in a lot of these situations because
I think talking about autism.
Yeah, autism and ADHD, I feel like, are two diagnoses that are a little extra complicated in the mental health field because they both require additional psych testing that you cannot get at like my office, for example. You cannot get psych testing. None of us do that.
Right.
But it's hard to get in. It's hard to validate. And again, it's hard to get those resources because resources cost money.
Yep.
And all our taxpayer money is going elsewhere.
Yeah.
So
and we don't know where anymore.
Oh God. But that's kind of like what we're like, what is the purposes behind diagnosing? And I, again, try to keep that in mind. You know, if I'm just trying to meet my clients where they're at.
Yeah.
You know, and with that client that I mentioned earlier that like did not qualify for certain diagnoses, like we still talk about that as a diagnosis.
Yeah.
You know,
like I'm sure you still treat it as if they have it.
Yes. You know, like, because that's what's valid for them. That's what helps them. That's what helps us talk about their symptoms, their life, whatever else. So I'm gonna keep freaking doing it. Yeah. And I did educate the client and whatever other, because they have other ancillary like support people part of their treatment, and educated them as well. That this is just kind of like the confounds of the limits of our practice, unfortunately. But that's why we meet the client's needs in other ways if we can.
Yeah.
Self-compassion?
We definitely want people to practice self-compassion, but that's so hard. Do you think about like the dumb stuff you've done in your past and think like, oh, what an idiot? That's not self-compassion. You have to forgive your past self, stuff like that. Like self-compassion is genuine self-compassion, like
it's
loving
hard.
yourself is hard.
Especially, and this is something that I think helps clients get to that point of self-compassion, is that past version of you doesn't have the information this version of you does.
No. And like, it's important. It's about forgiveness and learning and growing and honestly, like having some sympathy for your past self because they did, like you said, they didn't know what you know now.
And people, I think, really struggle to empathize with past versions of themselves because they have the whole story. You know, the past, present, future, and current, you know, like it's your life. So it's hard to separate that. It's hard to be like, oh yeah, if I put myself back in that moment, I don't think I would have been able to do it any other way than this. And that's so true so many times. Like truly, 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 when I have clients beating themselves up in my office and I'm like, let's put yourself back in those shoes, in that version of yourself. Like, did you really have any other options? And usually the answer is no. Usually the answer is like, this was the best course at the time.
Yeah.
And that's still so true. So we have to practice saying that version of me just doesn't have this information, but now I do. And so now I get to do something with that. Right. And that's the really exciting part, is I get to, you know, be more self-aware or advocate for myself or grow from this XYZ.
Yeah. You like to take your past self and wrap them in a blanket and give them a cup of cocoa.
Little special smooches.
Yeah. And be like, okay, you just made a bad decision and it's going to haunt you for a long time, but you didn't know any better. Just pat their head. You didn't know any better.
And you're learning from it now.
Yeah.
Yeah. I want to talk about intersectionality.
Oh,
I want you to talk about intersectionality.
Oh, okay. I would love to talk about intersectionality. Yes, I, a white male, will talk about intersectionality. I'm going to play my Jewish and autism card so that I can talk about intersectionality. First of all, let's define what that word means. So we talk about people being in different groups, right? Men, women, non-binary folks. We talk about race. We talk about socioeconomic status, that kind of stuff. All those different groups, they intersect with each other. So like I just made a joke. a white male is in a different intersection than a woman of color, for example. And historically, it's really important to recognize that in almost every situation across the entire world, women and people of color, and well, I shouldn't say just women, just people who aren't men, and people of color have been pushed down and marginalized by society. And it's important to recognize like the difference in experience between not only like me, a white male, versus let's say a black female, but also there's a significant difference between a black female and a Chinese female. There's a significant difference between a black man and a black trans woman. Like there's tons of differences across all these different things. So those intersections of those different groups is what we're talking about when we talk about intersectionality. And so when it comes to diagnosing, there's a huge history of like diagnosing being used really poorly and stuff like that. Obviously, like, I mean, even at the most basic examples of like homosexuality used to be considered a disease.
It was in the DSM.
Yes.
It was in the DSM-3.
Yes. And like,
Hysteria, which
gender
is
dysphoria.
Yes. I mean, it is currently in the DSM. Which I use often to, again, advocate for clients. Again,
because you have to use the diagnosis in the DSM.
Yeah.
Literally.
And anyway, this is kind of what I was talking about earlier when like a client in front of me might be experiencing something that looks like anxiety, but isn't or doesn't qualify for anxiety just because of some of these factors, right? Like I think a very common example is Black women in delivery rooms or in, pregnancy.
Incredibly high rate of maternal mortality, like double, triple maybe.
Yes, I think it's something like triple.
Yes.
Because of those factors, which is bananas, right? And I say this all the time. Therapy was created by white men for white men. So all of these diagnoses are kind like the baseline is white men. How it shows up in white men.
Yes, and all the research that has been done about it
has been on white men.
Yes, until like extraordinarily recently.
Yes.
And
even then, obviously now it's being defunded.
Yes, it's gone.
Yes. So especially for me, that's such a huge part of my practice is recognizing that majority of my clients are not white men.
Right.
I do see some, but like 95% of them, I would say, are not, and so I have to essentially like eat the DSM, digest the DSM, and put out something different.
Ew, from where? Why did you have to eat it and digest it?
I'm sorry, I don't know, but like
Could be a computer or something.
Essentially, what I'm trying to get at is like I have to essentially translate.
Yes.
That's a much. Cut that other part out.
No way, that's the clip.
But I have to translate the DSM so that it makes sense for the client in front of me.
Right. And like a really obvious example, like your client that you just mentioned, presenting with very, very typical adult female autism traits, which are not in the DSM. The DSM does not mention anything about women having prevalence of masking or anything about women whatsoever.
And I just want to note that I never identified my client as an adult female, but
you're right. You didn't say adult, but you did say she.
I tried. Really?
Yes.
Oh, damn.
Sorry.
I try to use non-identifying words the entire time.
Sorry. So, like, that's a huge failing in the DSM.
It's huge, right? And honestly, in practice, when we're being taught in schools, like now we have whole classes, and I hope that they continue to grow at the university level that help us understand and differentiate those things and be mindful of those things. And also too, like I think about my Latino clients that like many of them are first gen or immigrants that like this is the first time they're hearing anything about mental health. Like my parents, for example, when I told them I wanted to go into psychology, they're like, what's that? When I told them I wanted to be a mental health professional, they're like, you're going to starve. Like, no one's going to go to you. What is that? No, that doesn't exist.
And not to put your parents on blast.
No, I love my parents and they've done a lot of growth.
But like, like things like autism, it's like,
yes,
just education.
And it's taken a long time, and like I understand where they're coming from. It takes a lot of psychoeducation, and I don't mind doing that. But the same is true for, again, my clients in my office that like either have family members that don't believe their experience, or like, oh, it's all in your head, or like just pray it away, or
everyone has that,
or like I had to deal with that and worse, like all these kind of like devaluating comments. I think I still also factor in, like, again, I was saying, like, if I had a client that, meets certain criteria, like, I'm not just going to be like, hey, you have OCD, good luck. Like, hey, let's start treating your OCD, like there has to be nuance with how we introduce and how we talk about these things, and how we educate our clients too, so that it's not literally shocking and doesn't make sense just based on the cultural history. So anyway, all that being said, it is incredibly important. And I think therapists have the luxury of having hour-long sessions and where they can get into and get to know you. That's not a blanket statement though. Right.
Let's focus what we're trying to say about diagnosing.
Yeah. Why did I want to bring this up as a topic? At the end of the day, really just so that we can use these things to best benefit you.
These things meaning your diagnosis.
Diagnosing all the things that we had just discussed. Because it can be really complicated, and I think sometimes I have seen clients get stuck in a certain diagnosis, or get stuck pursuing a certain diagnosis. And sometimes that causes, like, again, more distress than not, or frustration around not getting the diagnosis. Like, there is just so much than simply like what we need to send to insurance. Like, that's just one part of it. There's so much that goes into it. And I think helping our listeners, our audience, our clients better understand these labels that have meaning, significant meaning and impact.
It's interesting. You mentioned a couple times, like, the billing aspect of it. So to send even your first session with a therapist to insurance, you need a diagnosis. So how much sense does that make? Insurance companies, the whole point is they're there to learn about what their diagnosis could be, and you're expected on day one to tell the insurance company what it is.
There are some, I'm not going to call them loopholes, but there are some tools that I use that kind of help buy me time.
Some codes,
like there's adjustment disorder, which is exactly what it sounds like. Person is experiencing an adjustment in their life, a transition in their life, and they're feeling distressed about it in one way or another. That is a 6 month long diagnosis code. So after 6 months, you have to provide a different diagnosis because, again, it's an adjustment. So it implies a period of time. But that at least gives me 6 months to better get to know you and better understand what's going on in your life, or for you to better understand what's going, so.
So like if someone comes in and they're like, I don't know what's going on.
Adjustment can be a helpful one. There's a lot of unspecified. So if you know some of your, like
unspecified anxiety disorder.
Yes. So if you're suspecting it can be anxiety, but they're not meeting all the criteria, or there's still some things that, we want to uncover, then having, anything unspecified. So ADHD unspecified, like all the diagnoses have a unspecified version of them. And so you can use those.
So it's the way that diagnoses are used is so strange and multifaceted in like the back end versus the front end, and like how people feel versus like whether it's like bias or not, and all these other things that we just talked about.
And honest, like the usage of it changes contextually, right? Like like when people used to be like, oh, she's so bipolar. Like we didn't even talk about using diagnoses as like offenses or whatever
exactly.
else.
Oh my God.
But that's also part of it, right? Like bipolar means something completely different in like colloquial conversation versus like in a therapist office in the hospital. Like
I would say depression and anxiety even.
Yeah, absolutely. Absolutely. Yeah. All of them. So yeah, we did not even talk about that, but that's also, I mean.
Yeah, the value of these words diminishing. But I mean, so yeah, I mean, diagnoses are complicated, y'all.
Yeah,
A lot to say about them.
We really appreciate you guys hanging out with us for this one.
Yeah. Sorry, we were a little scatterbrained.
I hope, I don't think that it's going to come off that way.
Oh yeah, I'm going to edit it out.
Yeah, but no, we really do appreciate you guys showing up for us, and we want to show up for you. So let us know how we can do that. Like I said, we really appreciate you being here.
Quick housekeeping.
Oh, yeah.
Vibe finally launching groups.
Yeah. So we talked about community a few weeks ago, and we were so inspired that we're like, let's
launch some groups.
Yeah, let's make some groups.
Let's make community happen.
Yeah. So there are 2 groups starting May 21st. I think that's a Wednesday. At 8 and 9. No, I lied. At 7 p.m. and 8 p.m. And these groups are, one is a support group for first generation individuals who are looking for resources to like navigate different things in this country that they might not fully know, right? And can just be helpful. Yeah. And then the other group is support group for adults with autism, or adults with ADHD. Both of them are in person, so you can show up, have a little snack, have a little convo,
meet some new people who might share a similar experience. Our groups are led by someone who shares those experiences.
Yes.
So we're really excited to bring that to you guys. And also, if you know somebody who's like, man, I can't get into a therapist. There's always a big waiting line. What the heck? Send them our way.
Yeah, we don't currently have a wait list, which is really wonderful.
None of our therapists have a wait list. Yeah. And all of them are licensed to do teletherapy throughout Illinois. So you can get therapy in your home, whatever. So, if somebody says that to you, send them our way. VibeTherapyServices.com.
Yes. I did want to say something more about groups. There are more groups on their way.
Oh, yeah.
There is a trauma group starting maybe in a month or so, led by Anissa, who is super trained.
Oh yeah, we forgot to mention the first 2 groups are headed by Mario.
Yeah, Mario Fernandez, who has a lot of experience in education and in counseling.
School counselor, yep.
So he will be running both of those groups, the first gen and adults with ADHD. Anissa will be running trauma, and later in the fall, Taylor will be starting a group
a DBT skills group.
Yeah, a DBT skills group.
Is Anissa doing a therapy group or a support group?
Therapy group.
Great. So yeah.
The secondary groups will be virtual.
Yes, the therapy groups will be virtual. Those are coming soon. But yeah, if you're interested or you know someone who would benefit from like that kind of community interaction, first gen, adults with ADHD, send them our way. VibeTherapyServices.com.
Alrighty, guys. Thank you so much.
Yes, thanks so much for hanging with us. We appreciate you. We will see you in a couple weeks.
Bye.
Bye.
That's such a millennial bye.
Bye.
Bye. Purple Friends is an independent podcast produced by Vibe Therapy Services and is not a substitute for a session with a therapist. Our show art is created by Jocelyn Lang, and our theme music is Nature Nurture by The Implied Bear. Vibe Therapy is an Illinois-based private practice serving clients in person at our Wheaton office and virtually throughout the state of Illinois. We accept Blue Cross Blue Shield PPO, United Healthcare, Aetna PPO, and Cigna Insurance. We also offer private pay rates as well as free 15-minute consultations. Therapy doesn't have to feel clinical. Visit VibeTherapyServices.com today to see if we vibe.